With that, we are going to transition to our next short presentation, which is a panel presentation of frontline practitioners that is actually looking not so much on where we've been with telemedicine, but where we think it's going to be going. And actually, we're going to bring up a short poll. I'm thrilled to introduce doctors Eduardo Fox, Tiffany Meyer, and Patricia Kapunan, who work in different roles around our region. But what we'd like to do is have you respond to this survey question.
So just so our audience is aware, we have about 5 questions here that you can answer before we get started. And our panelists will be mentioning these answers and alluding to them in their talks moving forward. So we're going to give you guys about 4 to 5 minutes to answer these.
No, 2 minutes.
All right, 2 minutes.
And while folks are doing that, I will quietly observe that at one of our earliest Business of Pediatrics sessions, 20 plus years ago, we had a guest speaker come and speak to our audience about whether the internet was going to change healthcare. And at that time, only half of our practices had a computer in their office. And it wasn't a warm reception. Over the last year or two, we've been talking about the uptake of telemedicine, and did we think this had a place and a role, and was it going to get reimbursed? And some great conversations about the potential. And then the pandemic hit, and all the rules have changed. And so now I think telemedicine is very much here, but what it looks like and where we're going, I think we're going to have some opportunity to sort of weigh in. And that's in part what this panel discussion is about a little bit.
I'm going to give everyone about 10 more seconds, and then we're going to close the poll and display those answers.
So in quick summary, there is definitely interest in these new models of collaborative telemedicine visits. You can see that the majority of our practices would characterize 10 to 30% of their current visit volume as telemedicine. Folks see much of that continuing. What type of visits do we think are going to continue? These acute urgent care visits and behavioral health and ADHD type visits seem to be leading the pack. And same answer for question number 5. So with that, I am going to turn that over to Ed, Tiffany, and PK.
Hey there, my name's Ed Fox. Thank you for asking me to be here today and share some thoughts. I suspect that I will share some thoughts that a lot of us share. There's not, I don't think I have any magic answers, but perhaps maybe when all 3 of us talk, we'll notice some common themes. I think the biggest lesson that we learned and we will apply going forward is that it works, right? And it works for a lot of what we do and for a lot of the folks that we serve, but it's not necessarily ideal for everything, nor is it ideal for everyone. And so figuring out those nuances and applying it to a hopeful post-pandemic world will be important. Back in April, May, we were probably seeing about 70% of our visit volume was through video. And more recently, we've seen an increase mostly in in-person visits. That probably mirrors what everybody else is experiencing. And so right now it's about 20 to 25% of our total volume that we're seeing by telemed. I think that what we would like to focus on going forward, and I posed this question that we're seeing on the slide to the core group of folks I work with on our telemed operations here at Goldberg at Children's. And really the focus was on making it easier to use for everybody. And that includes providing enough support for these efforts. And then also just focusing on making sure that the gaps that have been described by so many in many areas, unfortunately are also true for telemed, and trying to make sure we're not leaving certain segments of our population behind. To make it easier to use, we're really focusing on trying to integrate it further into our EMR. For many folks in the community, you perhaps are using a platform that you can launch directly from your EMR. We are not currently able to do that, so we are focusing on trying to figure out how to do that more effectively. And then basically from a support standpoint, sometimes I think as providers, we can sort of feel like we're going solo when we're doing our video visits, and there aren't as many established workflows for how do we engage support staff in the many tasks that we do during visits, especially for these well visits, right? Like how does all that screening happen, and figuring out ways to do that more effectively, again, using some sort of automated workflow is ideal. And I think that perhaps a lot of us in the community have different things that we can share with each other about what's working for us. So we will probably continue, just as a survey, the poll showed, we will continue to use it mostly for acute care and care coordination and chronic follow-up of chronic conditions. It's really, really effective. I think figuring out how to more effectively do these well visits that we have been doing, but I think for a lot of us and a lot of families, it seems like that isn't necessarily their preference. So we'll probably be using it more for acute care and follow-up visits, and just really focusing again on the access. I do feel like access from a technology standpoint has improved since schools went remote, in the sense that now families are so used to doing school remotely that going to the doctor remotely doesn't seem that strange or odd, and they're a little bit more used to it. But I definitely can share that at least for my low English proficiency families, it continues to be a bit of a hurdle to engage in the telehealth space. Now I'll hand it on to one of our other presenters and leave some time for group discussion.
Hi, I'm Tiffany Meyer. I am pediatrician in private practice, and I'm very happy to be a part of the panel. Thank you for asking me. And so we jumped right into telemedicine back in March when I guess a lot of us did, when we kind of needed to. It was something actually I had been wanting to do for at least a year, but I didn't really know how to do it. And I have to say, maybe one positive of this whole pandemic is that it forced us to do it. Ed was saying this too, but we're probably, at one point we were maybe doing a 50% or maybe 60% telemedicine. And then we're probably just above 30%, maybe low 30s percent of what we're doing now. Some of the things that that we've gone through as a group, and we've talked about ways to kind of make the flow better when we do our telemedicine. So we've tried, and it doesn't always work, but our ideal goal is to group our telemedicine visits at the end of a session. So if we're doing in-person visits, then we try to do, or at the end of our morning session, we'll do the telemedicines. At the end of our afternoon session, do telemedicine. It's not, obviously in an ideal world, that would be great. It doesn't always happen. It's hard to go back and forth, of course, between in-person telemedicine sometimes. We've also found that it's been very helpful to have a champion IT person. So one of our front desk folks kind of helps us and is supposed to kind of screen our patients to make sure that they're able to get into the system, and that they're able to conduct the telemedicine visit. And of course, we still do get frustrated because parents can't get in for some reason. And we right now have used, we're part of ECW, so we use eClinicalWorks, and we do the telemedicine platform through ECW. But there are times when different folks in our practice have used Doximity, and I myself have done it as a backup, because now Doximity has that video option. And so you can use the app, and then you dial their phone number and then request a video visit, and then the patient gets text. and then they notify you when they're on the line. So that's kind of been my backup, but I typically try to use ECW and then Doximity 1 out of maybe 25 visits if something really doesn't go well and I can't get connected to them. The other thing is that we've brought up here are what kind of visits. We did a few and a very few, probably less than, maybe 10 to 15 total visits of well visits. And of course, those are much harder to do, kind of the hybrid model where we've done it in 2 ways. The hybrid model where we've done the history part by telemedicine, and then we bring them into the office for a brief physical and shots or blood work if needed. But most families haven't necessarily been as receptive to that, and it's been a little more kind of logistically difficult. We put a special code in so we could go back and see which patients had those type of visits in the future, so we can kind of track those. But for the most part, most of our visits are either med checks, and those have gone super. I mean, they've been great. So our ADHD med checks, our mental health med checks have been great. We also do a lot of our GYN, our birth control med checks, which have run really well. Asthma med checks, folks who say, oh, I need an inhaler, but whoa, you haven't been in, we haven't seen you or talked with you in months. Those work really well. They don't necessarily have to come in. We've done a lot of derm visits, a lot of rashes. It really, really helps when they send pictures ahead of time. And then we look at the pictures and we do the telemedicine visit. So those have worked really well. We've also, as the cases are increasing, we've done a lot of our sick visits. So we'll start out any fever, any COVID symptom visits we'll do by telemedicine and then decide how we want to proceed, whether we want to do testing in our parking lot or can they just stay home and with reassurance. So telemedicine has been super helpful. I wanted to add 2 more things. Actually in care coordination. So I have several complicated patients. Sometimes they just need a letter written for Medicaid support. And I've been able to, and it's not time for their physical and they've had their physical, but mom needs to update me on some of the current things that are going on with the patient. I had one this week where mom and I discussed all the current updates on one of my autistic patients, and I was able to use that visit and then compose the letter that she needed. So it's really, I feel telemedicine has been such a blessing, and I've embraced it and I really like it. I see definitely going forward the med checks continuing. And then I wanted 2 scenarios I just wanted to give to folks just to know. I've had at least 2 incidences where I've had a patient who's needed a pre-op visit, and we require our patients to have an annual physical prior to a pre-op visit. And the feeling is that if we do the pre-op, they're not likely to come back for an annual physical. So I've had these patients where they'll come into the office and they think it's well, we've tried to contact them ahead of time if it seems like get on the schedule and they actually need a physical. But we'll let them know, today we're going to do your physical, but we can do your pre-op by telemedicine tomorrow, the next day, or within a week. So it's usually very closely connected to the physical, but we can kind of separate those 2 visits and they don't necessarily have to come to the office twice. And that's worked out well. And then the last thing I wanted just to bring up, folks, I think a lot of concerns are with telemedicine visits. Oh goodness, I can't code as high. It's not in person. And, things may change with the coding of 2021, but, there is some guidance out there that you can code a 99214 if a patient has, especially in these med checks, when patients have multiple chronic medical conditions. So if they have 3 chronic medical conditions, you can easily code a 99214 and as you're addressing them. And I want to give you an example. So ADHD would be one. Many of our ADHD patients have either anxiety, depression, some comorbidity, maybe autism, and that one of those is number 2. And then insomnia. How many of our patients, have trouble falling asleep? And we discussed that with them at the visit. So right there, you have an easy 3, right? And then our asthma med checks. We have asthma, allergies, and eczema. Right there are 3 chronic medical conditions. Those easily can be telemedicine 99214. So I just wanted to give some personal tips that I've used that I think are helpful. So.
Thanks, that was really useful. I'm Patricia Kapunan. I am the medical director at the Adolescent Health Center here at Children's National Main Campus. And I would say the most important lesson that we've learned is that telemedicine has unique value, both clinically and operationally. And our strategy going forward is going to be to demonstrate, expand, and to teach that value, not just to providers, staff, but to institutional leaders, and most importantly, to patients and their families. I think there's been a tendency to view telemedicine as a stopgap measure or a backup way to render services that we would ordinarily do in person, and that may go away when things return to quote unquote normal. But really it's more than that, as you've heard Tiffany and Ed describe so beautifully. It can be a way to enhance value as well as access, and yes, Dr. Weissman, productivity. At the Adolescent Health Center, we've done over 4,500 telemedicine visits with adolescents. I expect that we will exceed 5,000 before the end of the calendar year. We do about 14,000 plus visits a year, so it's a considerable chunk of our productivity. And we have tried to do everything that we usually do. In fact, when we were up to 90% telemedicine visits early in the pandemic, it was easier for us to talk about as a practice what we couldn't do on telemedicine in terms of sensitive exams, visits requiring procedures, to really define what it was safe to bring in person. But I did want to talk just briefly about both the clinical value and the operational, or how to get a higher resolution about the clinical value and the operational value. Those of you who take care of adolescents understand that they can be challenging to engage with, otherwise I wouldn't have a job. And it was quite a pleasure when we had never done any telemedicine, or we did very, very little telemedicine prior to March. We rolled it out very quickly in a couple of weeks. And it was amazing to see everybody, after they conducted their first couple of visits, just kind of go, wow. In terms of engaging with adolescents, doing it in situ, there's something special about it. And it removes some of the barriers that adolescents have to engaging with providers. There are other considerations in terms of confidential care, but there really is a value in terms of taking an adolescent history and the types of things that you're able to talk about when there is a higher degree of comfort. It has been amazing to actually follow our high school seniors, and many of you have heard me talk about how difficult 2020 has been for the class of 2020 seniors, and to follow them to college, which is something that we never did before. As well as all the connections that you've heard people talk about in terms of multidisciplinary teams, especially families with complex, families of children with complex medical needs who may have to go through a lot even just to come to a clinic visit. If they don't need to come to a clinic visit, and you can bring the parent advocate, the specialist, the wound care nurse, all into their home, that has been an amazing thing. We've also done things like invited a transition team, and invited the adult providers whom were handing complicated patients off, and done all that by telehealth. So there are amazing clinical opportunities, and identifying the specifics of these clinical opportunities going forward, I think is going to be really important in terms of how we implement telehealth in a way that increases clinical value. Tiffany gave a great example of medication management. Early follow-up after SSRI initiation is a HEDIS metric, and it's something I feel that that's easier for us to do now that we have telehealth as something that people are used to. The second thing I want to talk about is really figuring out what the value is to the community. I think we can't make assumptions as to why people don't use telehealth. I think so often I hear my colleagues say, well, they just don't want to do it. They're not coming in for whatever reason. And I think it's really important for us to understand how they use it, why they use it, because it might be a health literacy issue. There might be technology gaps that we need to address. And as we start to approach it as a unique clinical modality with its own value, understanding that it may have special unique value to the community in terms of addressing barriers to care and meeting their clinical needs in ways that they can't even imagine right now is really important. So I think it's going to be really important for us to take a detailed look at our metrics, what visit types, what are the patterns in utilization, and what can those tell us about how to plan for telehealth services going forward. And then the last thing I wanted to talk about is any part of a telehealth strategy going forward has to take into account what the unique challenges are related to this modality in terms of how to maintain confidential care, access to confidential telehealth visits, and as ever, the unique considerations for maintaining quality access, safety, and equity, which are going to be very different for this modality of care. That's what I got.
Before I get to the Q&A, one other piece that I guess the three of us would all say, although we didn't specifically mention it, and perhaps a lead into Lee talking in a few minutes, but incredible advocacy will be needed, as Chip referenced earlier, around reimbursement and payment. You know, we see the tremendous value. We're definitely, you know, pretty gung-ho about continuing to do this, but the reality is that we will need, we will need some way to support that work and make sure that it's reimbursed and paid for adequately.
There was a question in the chat about ADHD follow-ups and weight and blood pressure. There are several vendors, including DC Medicaid vendors, that are actually paying for blood pressure monitors at home. So that's something that we've been able to get for patients. You can also try a home weight, so that there are other ways to get around that.
There is a question around the ECW, specifically around the ECW telemed platform, and this will apply to other platforms as well. And someone asked, like, how do you decide on the best platform for your? It really depends a little bit on your EMR, how well it can interface. Doximity, as Tiffany pointed out, is really easy to use. So there are other ways to sort of use things outside of your EMR. For us, the ECW platform is very limiting because it only allows you to have one person on the visit. And so for the overwhelming majority of visits in community practice, that'll probably work pretty well. A lot of us here at Children's have learners or trainees, or maybe you need interpretation, and so you wouldn't be able to have those folks join in the visit, which makes it a very limiting platform as it stands right now.
And then there's a question about the HIPAA compliance with pictures. And so, you know, our patients are signing consent for visits and for telemedicine, and I believe it's part of that. Does anybody have any more information on that part? And of course, right now, a lot of the HIPAA stuff is being kind of under this umbrella of the pandemic. That also brings up the going forward, we're going to have to see where this goes. But I also have really enjoyed being able to follow a lot of my adolescents to college, and many of them are in college in the state of Virginia where I practice, but there are some that are out of state, and so right now I'm allowed to do that, and I don't know if in the future that will also be something I can do.
Yes, telemedicine does sort of challenge the boundaries of state licensure and those sorts of things, and the states have been very protective of owning their local licensure and permitting practice within those boundaries. But to Tiffany's point, that has been relaxed for the pandemic. Let's be optimistic. I think we, as a country, I think we will get our arms around the pandemic. I think we have validated that for our practices and our families, telemedicine really does have a place ongoing and going forward. I'd also point out relative to Chip's comments that in particular, in these next couple of months, pediatric practices need to be focusing on looking to see what they can do in terms of improving the number of well child visits back in person in their office setting, because that's the opportunity for staying engaged with our families, as well as significant revenue. As Tiffany pointed out, telemedicine also offers some ability to sort of pre-screen acute illness, to try to figure out how we are going to manage the arrival of those kids, and in terms of isolation or testing or distancing or those sorts of things. So these are new tools for us. Payment is going to be a significant issue going forward. I will observe that many of the insurance plans have been pointing patients to teledocs, outside of the primary care practices and medical homes as ways for them to save money, but haven't really been highly engaging and supporting of pediatricians taking that on. I do think on the other side of the pandemic, the cat's out of the bag, and it's not all going to go back. And so it will be up to us, our local chapters and at the national level and others, really to sort of advocate for appropriate ground rules and reimbursement to sort of support this as being part of our day-to-day practice routine, because it's becoming routine. Hard to believe. I want to thank our panel. There are a couple other questions out there, but I want to be sensitive to, we have a jam schedule, and we are ending with some important keynotes that sort of focus on next steps for our country and pediatricians as it relates to the election. And so thanks to Ed and Tiffany and PK, Patricia, and we will transition now to our last section,